Hi, this is Anu, and you're watching Anna for Nurses. Today, we are going to discuss about thyroid gland, the overall view about the thyroid, like what all are the hormones produced by it, what are the functions, and some disease conditions of this thyroid. Hope you remember the anatomy. From the hypothalamus, there is TRH, thyroid regulating hormone, and that is stimulating your anterior pituitary to produce TSH, thyroid stimulating hormone, and that stimulates your thyroid gland to produce the important hormones. That's a T3, T4 mainly. This thyroid is actually made of follicular cells. And remember, unlike other glands, thyroid secretes or synthesizes these hormones and stores in it. And when the TSH stimulates, it just releases these hormones into the bloodstream. That's a major difference to be remembered. So this is actually produced from thyroglobulin, which is a protein producing this T3 and T4. That's a triiodothyronine and thyroxine. There is one more hormone called calcitonin. Hope you know that calcitonin is working or functioning in opposite to the parathyroid hormone or parathormone. If parathyroid hormones are helping to maintain the blood level calcium, calcitonin is like a tone. It tones the teeth and bone. So it helps in the mineralization of the bone and teeth. That's the main function of calcitonin. What about the T3, T4? Thyroid hormones mainly help in increasing the basal metabolic rate. So you can basically call them the metabolic hormones. And along with that, it increases the cardiac output. It also activates the sympathetic nervous system stimulation. That's what the patient will feel like you must be remembering about this when you studied adrenal gland, fight and flight response. But the major ones are the catecholamines, but this also activates the sympathetic nervous system. That's why in hyperthyroidism, patient becomes hypervigilant and all. And this the bone resorption, that's mainly by the calcitonin. Mainly, why thyroid disease is occurring? That's mainly due to the iodine deficiency, because you can call these hormones as iodine hormones. So iodine and thyroid, that's a very important relation. So remember that always there are iodine hormones and there is iodine deficiency. It definitely affects your thyroid gland. Then when you take the types of the thyroid diseases, or when you there are some terminologies in relation to this you need to be knowing. First of all, what is the primary and secondary thyroid problems like hypothyroidism or hyperthyroidism? Primary is always related to the gland itself. If there is any problem with thyroid gland and this is leading to the condition hyper or hypo, you can call it a primary. Secondary will be always if the problem is with your hypothalamus or pituitary. Then another important term you should be remembering is the Graves' disease. It's an autoimmune disease and it's usually associated with your TSH receptor antibodies. And these actually mimic like TSH, so it stimulates to produce too much of thyroid hormones. And remember, this is the major or the most common cause of hyperthyroidism. If questions comes, this question has come before in your exam. So which is the most common cause of hyperthyroidism? No doubt it's Graves' disease. Another term to be remembered is pretibial myxedema. You can see I'll show you one picture. Tibia, you know where it is. It's a lower leg bone. And over that tibial area, there will be discolored, waxy, edematous appearance. This is seen mainly in Graves' disease. It's called pretibial myxedema. And there some features are very specific to Graves' disease like exophthalmos, diffuse goiter without nodules, and this pretibial myxedema are the three important characters that specifically seen in Graves' disease. Next one is thyrotoxicosis. It's like toxicosis. Anything that is excess is called toxicity. So abnormally excess quantity of thyroid hormone in body is called thyrotoxicosis. So it is hypothyroidism again. Another term is toxic multinodular goiter. You can also call it as plumber's disease. This is hypothyroidism with firm nodules. You can feel that nodules on palpating this thyroid gland. This is called toxic multinodular goiter. Another term is cretinism. That's a congenital thyroid deficiency. Usually the children born with cretinism will be having physical problems, and along with that mental abnormality, that intellectual level problems will be there, and they will be having delayed milestones and all. So cretinism is congenital thyroid deficiency. Another one is myxedema. Myxedema is, there is a difference between myxedema and myxedema coma. Remember that always. Myxedema means the patient has hypothyroidism, but it was like undiagnosed, or patient knows that but not taking the follow-up measures or seeing the TFT and not taking the medications. It means untreated, neglected. So in those patients, when there is a long-term low level of thyroid hormones, will be leading to a condition called myxedema. But myxedema coma is most of these endocrine problems, when they face some stress or infections or some surgery, they will be facing crisis of that problem. So that's what every time when the patient has some endocrine problems like diabetes or thyroid problems and all, there will be one review just before your surgery. There is surgery and all, we will send one review to that endocrinologist to see whether there is requirement of any dose adjustment and all. They always anticipate like these crises shouldn't come. In case of this adrenal problems and all, if they are getting tablets, they will be given them IV shots prior to the surgery, so in order to avoid this crisis. So in hypothyroid patients, if they are facing some surgery or if they happen to have some infections or any other stress, this can lead to myxedema coma. Remember, both are different, myxedema and myxedema coma. Then one more term, that is Hashimoto's disease. We said Graves' disease is like an autoimmune disease. This is autoimmune thyroiditis. Thyroid got inflamed. Initially it will be like a hyperthyroid features, but usually will be manifested as hypothyroidism. So Hashimoto's disease is mainly autoimmune thyroiditis. These are some important terminologies to be remembered. Next is diagnosis. Mainly we will be doing TFT, thyroid function test. Always you don't see the TSH, you all should see the T3, T4. If T3, T4 are low, it is hypothyroidism. T3, T4 is high, it is hyperthyroidism. And TSH and T3, T4 should be inversely related. If T3, T4 is low, TSH has to be high. T3, T4 is high, TSH has to be low. That should be the normal scenario. But something called primary hypothyroidism and secondary hypothyroidism, right? If there is problem with your thyroid, there will be low T3, T4, and because of low T3 and T4, your pituitary will be producing more TSH. But your thyroid is not able to produce T3, T4, release it. So the problem is with your thyroid. It is primary hypothyroidism. In that, high level of TSH will be there. But what about the secondary? If it is secondary, this T3, T4 is low because TSH is low. And then you can guess the problem is not with the thyroid. The problem can be from pituitary. So this is how you will diagnose it. And other things you can do is you will be doing a thyroid scan or a radioactive iodine uptake test. Remember which is the isotope we are using in this iodine 131. Now let's see the difference between hyper and hypothyroidism. We already said it is a metabolic hormone. So mainly in hyperthyroidism, you will have a very high BP, tachycardia because of that palpitations, weight loss. There will be lot of temperature thermogenesis happening. So patient will be having heat intolerance and because very sweaty. And remember, the skin won't be dry. Skin will be very smooth and sweaty. Hair will be smooth. Bulging of the eyes is exophthalmos. Goiter, diarrhea can be there. What about in hypo? Opposite of this. Low BP, bradycardia, weight gain can be there because the metabolism is not happening, and this temperature, that the cold intolerance, they will be feeling very cool and their skin will be dry. They can have alopecia, so hair loss and dry brittle hair, all those problems are with hypothyroidism. And the periorbital edema, they don't have this exophthalmos and all. Periorbital edema is not in all hypothyroidism patients, it's mainly seen in myxedema patients. And generalized edema can be seen in some patients, and also constipation instead of diarrhea. These are the important features of hypothyroidism and hyperthyroidism. Some miscellaneous features are also there to be remembered. That's a low libido, fatigue, depression. All these low can be related to hypothyroidism, definitely. Also, they will have menstrual disturbances like amenorrhea or irregular periods, hypomenorrhagia. Mainly amenorrhea, irregular periods will be their problems. So these are the important points to be remembered in relation to the signs and symptoms. Very easy to remember actually. Hyper means all, like hyper. Hypo means all, low. So that's all. Now the diet. What kind of diet to be prescribed for these patients? Since hyperthyroidism patients are very thin and lean, weight loss will be there. You have to give them high calorie with lot of protein, carbohydrate, and give small and frequent meals, and no high fiber because they have diarrhea, and stimulants like caffeine, spicy foods to be avoided. In hypo, you need to give a low calorie. They already have weight gain and all, and low fat diet. Frequent respirates, they will be always tired. So frequent respirates is important. Since they have constipation, you can prescribe them a high fiber diet. This is the diet to be prescribed. When you remember the signs and symptoms, it's easy to remember the diet also. Now regarding the treatment. For the hyperthyroidism, what's the treatment? We said like palpitations are there, too much of thyroid hormones are coming. So sometimes it can be some tumor also. So for the tachycardia, palpitations and all, you can give beta blockers and too much of thyroid hormones, anti-thyroid drugs to be given. And the first line of management is carbimazole or methimazole. Initially, we'll be starting at a high dose, then slowly they will be titrating the dose, and within 18 months it will be stopped usually. And there is a second line management called PTU or propyl thiouracil. Remember, PTU has got some side effects, like it can cause the blood counts to be low and some liver reactions. It's a small risk for the liver reactions, but mainly the blood counts will come down. So the patient can have like sore throats or complaining of any tiredness, easy bruising, shortness of breath. You need to suspect the side effect and they need to report to the doctor immediately. So regarding the patient education part, this thing to be kept in mind. Decreased blood counts, so what education to be given to the patient? That's a question area. Then after this, mainly for all these tumor related problems, surgery. When you do the thyroidectomy, then the lifelong replacement with thyroid hormones is necessary. That is to be explained to them. Now which drug is safe in pregnancy? Whether it is carbimazole, that's a usual first line of management, or PTU. Actually, PTU is safe in pregnancy than the methimazole. If they are pregnant, they can go for this PTU. Then radioactive iodine. We already said radioactive iodine we'll be using for the diagnostic test. It also helps to shrink that size of the thyroid, destroy some of the cells of the thyroid. So it's also considered to be a part of treatment for the thyroid. But it takes up to some 6 months and all. The problem is the patient cannot become pregnant. It's radioactive, right? So cannot become pregnant, or at least a 6 months gap from the therapy to get pregnant. They should use contraceptives, and they shouldn't have big like with close contact with kids or other pregnant women and all. This need to be taken care of. This is another patient education area you need to be remembering. Next is, that a Lugol solution or SSKI. That's a strong solution of potassium iodide. The thing is, it can stain the teeth And usually it has to be spaced 1 hour from other thyroid drugs. It shouldn't be given along with other drugs, especially with the other thyroid drugs. That point to be kept in mind. That is also an examination point. Now for the hypo treatment, you will be, it's all low, low, low. So you need to supplement the hormone. That remember, there is no cure. It's a lifelong replacement. When there is a gland problem and you're treating that, it is that replacement to be lifelong. There is no cure. That's another patient education part you need to be remembering. And these thyroid hormones need to be given early in the morning, and that too in the empty stomach. That is to be remembered, early morning, not in the afternoon or any other time, and in the empty stomach. And there is no abrupt stop. They shouldn't stop it immediately. It can lead to mixed edema coma. And also, if they're missing one dose, no, like it's not like doubling the dose. If immediately they remember within that half day, that they can take it, that missed dose, as soon as possible, and maintain some fasting after taking the drug. But usually the next day, if they are remembering that I just forgot to take the yesterday's dose, they cannot take the double dose. So that is another important patient education part you need to be remembering. It's usually, ideally, should be taken early in the morning, and that too in the empty stomach. Now, what are the things to be avoided by them? They should avoid narcotics like opioids and all, and also sedatives. Hypothyroid patients should avoid these. So this is also an exam point. Then, thank you. We'll continue with the remaining portions in the next video.